Hello, everyone, and welcome to the webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience today how to ask questions throughout the webinar. Our speaker will try to answer as many as possible at the end of the presentation. I'd like to introduce our moderator for today, Lexi Caraway. Lexi is a registered therapist at the Carl Richland Memorial Hospital in Olney, Illinois. Lexi is an active member of the Illinois Society for Respiratory Care's Board of Directors, serving as delegate and PAC co-chair. Recently, Lexi presented at the AARC International Congress on the topic Capturing a New Perspective on Pressure Injuries, Thermographic Imaging. Lexi, welcome.
Thank you, Tracy, for that kind introduction. The title of our webinar today is Medical Device Pressure Injury, Recommendations from the Secure Prevention Consensus. Our speaker today is one of the nation's leading experts in pressure ulcer awareness and is a co-author of the Secure Prevention Consensus, Dr. Joyce Black. Dr. Joyce Black is the Florence Needfelt Professor at the University of Nebraska Medical Center in Omaha. She has received awards from UNMC and the college for her teaching. Her research areas of interest are in wound healing, specifically in pressure ulcers. Dr. Black's dissertation examined the patient and wound factors that contributed to healing or non-healing of diabetics with pressure ulcers. She is certified in wound healing and was inducted as a fellow in the American Academy of Nursing for her work in deep tissue pressure injury. Dr. Black is the current president of the National Pressure Injury Advisory Panel and was the co-chairman of the NPIAP's task force to redefine pressure ulcer staging. Our speaker has disclosed the following relationships. She is a member of the following Speakers Bureau, and she is a consultant for the following companies. This activity has been approved for 1 contact hour of continuing education. At the end of the webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. Please see the accreditation statement below. This activity is supported by an education grant from Dale Medical Products Incorporated. And now I will turn our presentation over to Dr. Joyce Black.
Thank you, Lexi. I appreciate the opportunity to speak to all of you today, and I appreciate the introduction from Lexi. We share some things in common. We might have to get together and talk about these pressure injury pieces. So I presume you attended or are attending this webinar because you're seeing an uptick in the number of pressure injuries in your facilities, in your patients due to medical devices. And of course, that's exactly what we're going to talk about. So I'm going to launch off of what was 2 publications called the Secure publications, and you can download those for free off of the internet. And I'm going to drill down a little bit more into some of the most common medical device injuries that we see. So we're going to look at locations of several, and then what I want to really focus on is how do we prevent them? How do we reduce the duration and magnitude of pressure? Because that's really the culprit in these pressure injuries or pressure ulcers. And then as Lexi just talked about, she's interested in pressure injuries, and I'm going to guide her how to guide the respiratory therapists to give us some help. As nurses, we need to work together on this one. So as I was just saying, there were 2 documents that were produced. The one with the kids was the first ones on your right, and the one with the egg, just about ready to break, was the second one. And they were, the group that worked on them is listed there for you. You can see it was a nice multidisciplinary group published by the Journal of Wound Care, which comes out of England. As far as I know, it comes out of England. So I'm going to send you to these for some of the detail that you'll need. Now, as I speak, I know I'm going to interchange the words ulcer and injury. So let me explain a little bit of the story. Initially, these wounds were called medical device related pressure ulcers, or MDR-PU. Then in 2019, I co-chaired an effort by the NPIAP where we changed the word pressure ulcer to pressure injury. And so the name of the problem became the medical device related pressure injury. But of course, there's always more to the story. But because we included non-medical devices like hearing aids and eyeglasses in the list of products that are known to produce pressure injury, the word medical had to really come out. So today, the term is device-related pressure ulcer, depending on what part of the world you're in, or medical device-related pressure injury, again, depending on what part of the world you're in. So if you do a web search for this, or you do a lit search with your librarian, be sure you give her or him both sets of terms. So the beginning of the story for this problem actually started with a number of patients that we had at Nebraska Medical Center. And when we did our quarterly pressure injury incidence and prevalence numbers, we were seeing, I mean, we knew they existed, I won't say that. We were seeing an increasing number of pressure injuries from medical devices. And so we did a study, which I'll share with you in just a bit, that opened up the door for improved understanding. The first thing we did was to find the problem as a localized injury to the skin or underlying soft tissue resulting from the use of a device that was applied for either diagnostic purposes or therapeutic purposes. And in our critical care patients, we have many of these devices. The difference in this problem is that it's easy to figure out what caused it. So if you look at the patient in the photograph, that's a paraplegic patient, and you can see very easily a very deep stage 2 pressure injury on his ischium. Someday we can talk about that wound if you want to, but what we're here for today is to talk about the other 2 wounds that he got from the Foley catheter, from the aspiration port and from the connection of the rubber part of the Foley to the plastic tubing. Now, these things tend to evolve quite rapidly because in many instances, they are on body parts that have very little adipose tissue. And we'll look at a bunch of those. This is where Lexi and I share some common ground in that the most common location for these wounds is the face. So here is our first patient. This is a picture many years old. This man obviously had nasal cannula on, and when the wound team saw him, he had wounds from the tubing under his nose on the malar eminence, which is his cheekbone, under his chin and behind his ear. And we took a while to understand what was actually going on. And what we found out is that he would move about in bed and he would knock the nasal cannula out of his nose. His sats would fall. We'd get the alarm, the one of 17,000 alarms every day. We'd get the alarm, we'd go in, we'd find the nasal cannula over on his cheek, we'd put it back. And one of the nurse techs said, well, the reason it's coming out of his nose is it's too loose. So she moved the lariat up really tightly. And so the tubing was pressing throughout his face. They've been around for a while, as you can see on the slide. We've known about particularly oxygen delivery devices leading to problems. And what I think you're probably seeing in your facilities is there's a high number of these things, particularly if you look at percents, because the percent of your sacral injuries and your heel injuries are probably going down. And what's occupying the pie chart, if you will, are medical device injuries. A number of years ago, I was asked to speak on this topic, and somebody, not me, called it low-hanging fruit, that we ought to be able to get rid of these pressure injuries really easily. They're low-hanging fruit. My argument was through the entire talk, these are not low-hanging fruit. We can't move all of these devices. We can't move their place. We can't unstitch the trach. So I don't think they're low-hanging fruit. So be careful that you don't start to believe that there's something that is easily fixed. I don't think that's the case. Most of the devices that we apply are hard plastic. Most of them have not been redesigned. Well, I'll get to that later. In a very long time, the microclimate, the sweat beneath the device and the skin, makes the skin more likely to break down. What we see a lot in critical care is when patients come into the hospital that are septic, they're very dry, and we start to transfuse lots and lots and lots of fluid and sometimes blood. And we have put pounds and pounds and pounds on these patients. So the devices that we applied in the ER or inserted in the ICU, by the following day, the tissue is so edematous that they break down quickly. And then on top of that, there's not 100 sizes. I mean, when you think of the Foley itself, at least in adult medicine, we have 2 French sizes, at least we do, 14 and 16. That's it. We can't change the length. We can't change anything else but the size of the catheter. So all of that creates an issue for us. In children, pressure injuries from medical devices are the leading cause of injury to children. And a lot of it, like in the adult, these devices were applied prior to fluid resuscitation. And I think a little more unique to the kids, because nobody wants to put this thing down again. Think about the NG tube, think about an ET tube, think about an IV. Nobody wants to be called in the middle of the night to put this thing in. So they tape them down very, very securely. And between the tape and the device, they get pretty significant injuries. You may think that medical device injury doesn't become serious. So the low-hanging fruit story. But there was a study done a while ago where they looked at how serious these wounds are, particularly, and this was all children. These were actually neonates that they studied. The columella is the piece of tissue that goes from the point of the nose to the top of the lip. So it's that little bridge. Those became necrotic, and the kids needed plastic surgery. I've seen endotracheal tubes leading to pressure injury that needed plastic surgery. So don't fool yourself that these things are modest, because they're not. Now, when we compare a pressure injury from a medical device to what I might call a classic pressure injury, the etiology or the cause of the classic pressure injury is the compression of the body against the surface. So this is a patient who came to the clinic paraplegic, had, as you can see, a significantly necrotic septic wound on the ischium. Now, that wound would only occur in a paraplegic because that something was wrong with the chair cushion, and that's exactly what it was. So the pressure can be intense, leading to deep tissue injury, or pressure can be prolonged, leading to the classic pressure injury, the stage 1 to 2. So a little bit different in that we can quickly identify the cause. So the secure document really does a nice job explaining the etiology of these medical device pressure injuries. So again, depending on how tightly the device was applied, we can actually destroy muscle cells and get the classic deep tissue pressure injury. So giving you some examples, those of you that work with ECMO know we can't do much with the ECMO cannulas. They are tied very tightly. They're sutured down. We can't move or remove them. Splints or braces placed on edematous legs. I'm going to leave you with some parting words on that. And then CPAP on the bridge of the nose. That is the most common location for a medical device injury. And then the more classic form, compressing the arterial flow. We see that in the oxygen tubing. We see that when we have elastic wraps wrapped too tightly. And then finally, the issue of microclimate, which may be a new word to some of you. Microclimate simply is talking about the sweat between the surface of the skin and the underside of the device. And when microclimate rises, it makes the skin macerate, and macerated skin does not tolerate pressure. So that wound would be the trach flange with the patient who's got lots of humidity from the trach collar combined with the mucus from the airway. So this is a figure from the secure document, and it just does a nice job going through everything I went through with you just a second ago, except I'm going to focus you for just a second on the green ovals. So what happens in any pressure injury is there's an inflammatory response. That's the body's natural way of dealing with any injury. No matter what happens to you, there will be an inflammatory response. So that's probably why we're seeing a lot of anti-inflammatory drugs being advertised today. The temperature of the tissue increases. It's a combination now of external temperature as well as internal temperature from the inflammatory response. And when that tissue is moist and wet, it doesn't tolerate pressure. And so if this is a moving device, if this is something that moves on the face with breathing, moves as the patient turns, you can get what the engineers call the coefficient of friction. Don't fall over that. That's just friction. So if you rub your hands together, you're creating friction. And when you do that, your hands get warm, right? Now, here where I'm at, we've got a lot of ice. So if you made that ice wet, there'd be no friction on it at all, and we would all slide for a good bit of time. So don't be alarmed at the engineer's term. It's simply friction that you know. This is another document from the Secure article, or books, I should say. They're almost books. They're almost like a journal. Going through the same idea that we've been talking about, which is the interface of the skin to the device. And so all this is saying is if we look at the size of the device, we're going to have very high pressures if it's a small device that's pushing. Think about pushing on a needle. It's pretty high pressure. It's going to pierce your skin. Versus, you've seen this, people are laying on beds of nails and have no injury. That's because we disperse the pressure. So that's really what this nice drawing is talking about. So what I did with this photograph, our series of photographs, is just reminded us that we can get device-related pressure injuries or pressure ulcers from anything and in any stage. And so as you look at these are the 6 stages of pressure injuries in a range of ages of people and from a number of devices, which we'll get to in just a second. As I said at the beginning, we are all seeing a huge uptick in the percent of pressure injuries that we're seeing from medical devices. So these are pediatric patients. This was a study done in pediatric patients. And as you go across the chart from left to right, you're going to see that the blue bar gets bigger and bigger, and the purple bar, which represents which represents pressure ulcers or injuries from immobility, that's pretty stable. So these patients are probably being cared for in a very proper way. It's just we've got a big uptick in the device injury. So I think we're all seeing that. The other thing that device-related pressure injury can do is appear on mucous membrane. And I think most of you are familiar with the work that I did with NPIAP. It's been a while ago now, where I said, and NPIAP agreed, that when a patient has a pressure injury on mucous membrane, you can't stage it, because the staging system was designed for skin, and mucous membrane is anatomically not skin. Now, a few of you have probably sent me photographs over the years saying, help me with this one, help me with that one. And I can tell you that, for example, when you have a pressure injury on the nose from an NG tube, you've got a wound on the external nair, and you've also got a wound inside the nose from that tube. And so I get asked, how do we stage that? Is it a mucous membrane wound, or is it a stageable skin injury? My answer has been and will continue to be, you stage to the worst. And so the skin would be a worse injury than the inside of the nose. NPIAP is going to come out with a little more work on this. It's one of the initiatives I've taken on as president of the panel. And so hold on. Hopefully I'll get an answer for you. It's not going to be an easy answer, because some of these tissues are not well understood. I can't get a histological picture of some of the tissue. So hold on, we'll get back to you, as they say. So this was some work now done in adults, and you can still see that there's a huge number of pressure injuries in this population. 28% was the incidence. So that means This is a pressure injury that was not present when the patient came in, but developed during the hospital stay. 28%, that's higher than your general hospital incidence, which is probably somewhere between 2 and 5% in most hospitals. You can see that in one unit of the hospital, 100% of their injuries were from medical devices. And you can see in the pie chart, I'll help you out a little bit, the blue and orange pieces of the pie were category 1 and 2, both at 38%. So we're starting now into, okay, what devices am I worrying about? And in our hospital a number of years ago, when we first started recognizing the frequency and the issues with medical devices, all of us on the wound team would go into our room, our office area, and start writing down the names of the devices. So I saw a pressure injury today from X device. Well, when it got up into the 40s, there really wasn't any particular need to write them down anymore, because we basically ended up saying any device you put on the body can lead to a pressure injury. So let's just try to figure out how we can fix that. So here's places on the body and the device itself. So if you look at the orange circle, you can see that it says right at the top of the numbers, it says immobilizing device. I'm going to go through with you casts and splints at the end. They are a big problem, and I want you to be very comfortable with your recommendations for the staff on those. So you can see that there's 20 here, but there's many more out in the world that we see. We know that the majority of mucous membrane pressure injuries occur in the critically ill. They are almost all from the endotracheal tube, the oral tube, the NG tube. All of those pass through mucous membrane. There are also some devices that are from Foley catheter injuries, I should say, from Foley catheters or fecal containment devices. And so what this study looked at was how quickly does it take to develop a pressure injury on the lip from an endotracheal tube. And what the conclusion of the study was 3 days. And so we need to work, Lexi's agreed to help, we need to work on how do we reduce the risk of that injury in our critically ill. So when we look at the secure document and the prevention that it recommends, there were a lot of themes within the document. And I think when you get a chance to read it, you will see it. Now, generally, the conclusion was that a lot of these device-related pressure ulcers were preventable. And I completely agree. If we can come up with some approaches that work, we need to get the proper size. We need to secure them without taping them down so the patient could go to the moon. We need to get them out of the patient or off of the patient as soon as possible. Now, if we can't do those things, then we've got to pad the interface between the device and the skin. And I think you will see that that will help. If you're not doing that, you should start padding, because we can't remove all these devices. And then, to me, kind of obvious, don't put the patient on the device. But you and I have found devices from Foley tubing, or found injuries from Foley tubing, right? Patients laying on it. So probably needs to be said. I'm glad they said it. Here's the most common set of medical device pressure injuries. It's the oxygen delivery devices. So let me go through the 4 pictures with you. Starting in the upper left, that's a patient with a wound from a tracheostomy tie. The wound eventually eroded one of the major arteries in his neck, and he hemorrhaged to death. The wound on the upper right is a patient of ours who was on the liver transplant list. And it's odd, he actually said he did not want to go through intubation. And I thought, well, I don't know how they're going to do that transplant without intubating you, but okay, hang on, we'll agree, we'll abide by your request. He came into the ER in acute pulmonary edema, would not be intubated. So a CPAP mask was placed on him, and this was his face 24 hours later. He had been up They diuresed him. They took the mask down. He saw the nose, made a number of statements about this should not have happened to me. How can this be okay? So we had plastic surgery, see him repair the wound. I don't think he ever sued the hospital because he was still on the liver transplant list. But he brought to our attention that when the wounds are on the face, they're gonna be very concerning to the patient because they didn't come in with, you didn't say to them before you put the CPAP on, oh, and by the way, by tomorrow morning, you could have a full thickness wound on your nose. So be careful with that one. The bottom right, of course, is an endotracheal tube, and the bottom left is the guy that we looked at originally. So some of the issues with oxygen delivery devices is the facial contour of everybody's very different. Some people have very thin and have bony faces. Other people have edema or fat faces. So it's not like we have a one size fits all. In addition, airway leads, right? Lexi will not argue with me at all about that, right? When people are in distress, it's their airway. Everything else gets put to the side. And that's what's driving some of these processes is airways number one. And you know, the effort to secure the airway kind of trumps the need to keep the skin intact. And then there has been a lot of people who believe that you need to strap that device down as hard as possible. And so when I look at the epidemiology, it fits. It's what I just said. This is just a little data. I'm not going to spend a lot of time on it. We've talked about it. Respiratory devices, oxygen tubing, CPAP, BiPAP, all of those things lead to, there are very high frequency of devices, both in adults and children, and lead to oxygen delivery device related pressure injuries, basically, which we lump them all together. So, okay, what do we do? The first thing I think you need to do is get a preventive dressing on the bridge of the nose and off underneath the eyes, which is called the malar eminence. And you need to put that on. It doesn't need to be particularly thick, a thin dressing, not a film. And I would not encourage a hydrocolloid because you're going to have a hard time getting it off the face. Now, for a while, we tried to put these right on the mask. So we tried to kind of bundle them together. That didn't work. So today they're in the ER, right behind the patient. So you don't have to run to the Pyxis and get one because airway leads. And if it's going to take me 2 minutes to get back to the room to put the dressing on, I'm going to find the mask is already on the patient, and rightfully so. There is some work. And I'd be curious what Lexi's thought is, that you don't need this thing clamped down, this mask clamped down. It is okay to have a small leak of air. And then from the nursing perspective, get the patient out of the CPAP or BiPAP and instead use a full face mask or a nasal cannula, whatever will support their O2 sats. And of course, ask about facial pain in those. This is a little more data on the kids for oxygen devices. Sometimes the devices, children grow rapidly in the first few months of life. And so we don't have devices for every age of a child. And so you need to look at how can I get the nasal prongs in without destroying the anatomy of the nose? How can I get the mask on without pushing on the face to the point that there's actually been reported injury to the gums and the teeth don't appear normally due to the use of CPAP and BiPAP. So lots of issues with that. The oral mucous membrane, airways, number one. There are people who don't believe that these are particularly serious because it's the mucous membrane. But as I said, we've had patients who've had severe enough wounds that they've had to have plastic surgery done so they could swallow. So the way to manage these is to rotate the tube. And we have worked with our respiratory therapy folks so that every 2 hours, when the patient is being turned is the easiest, is to change the position of the tube in the mouth. And so the securement device you use should allow for you to move the tube back and forth, and that way you can see the lip and see what's happening. Now, a word of caution, I know that you're still proning some patients. The device on the bottom, that's one of our patients. You cannot prone a patient with that device on. That was never intended for proning. So be very careful. You're going to have to get a softer product or straight out tape the device if you prone the patient. The oxygen tubing wounds, we've talked about this a little. Here's some suggestions. Make sure you check the skin. Ask the patient if there's pain in their face from it. Pad the back of the ears, and then switch to a silicone oxygen tubing if you can. Facilities that have switched to silicone oxygen tubing have found amazing results from it because it does not press down on the skin of the face as much. So if you're really struggling with that, you might want to look at the silicone tubing. Well, those of you that work in critical care know that the pulse oximeters don't work on the fingers, don't work on the toes, don't really work anywhere, but the forehead and the ears. And so this is, you can see this is an old picture. This is a patient who had the clip oxygen saturation measurement. And if you're interested in how much pressure that thing puts on the skin, nice study done by Goodall 10 years ago, and there's been nothing since, where she laid out how intense the pressure was. And so what we have seen is a lot of blistering type burns, so a stage 2 pressure injury from these devices. And of course, some of our staff have said, well, maybe the oximeter heats up and this is a burn wound. Well, I don't think that's the case. There is a light, but I don't think the light is enough to burn. But the problem is we've got to keep track of the O2 sats. And, you know, obviously some patients desat pretty quickly. So our method, we've gone to some other devices, but when we need to use the clips, we move them each time the patient is moved. And you can see, I think you can see some of the serum that is draining from the blister that has been on his ear for a while. Like I said, there's a closer picture of the man who died from the trach wound. Airways number one, you're not going to be able to argue that, but I think there's some other things that we might do. In surgery, most of the time, and I know that trachs are put in the ICU as well as in the operating room, the trach itself, the flange or the face piece, is often sutured extremely tightly to the skin of the neck. I know that nobody wants that thing to come out. I understand why. But we need to look at what we can do to slide a dressing under that before they suture it in, because the pressure comes from the trach flange. Now, in patients who are obese and have thick necks, the ties from the trach can get lost in the back. So I would encourage you to follow the trach tie all the way around when you do trach care. And as I said, the proxemics to the large vessels can cause fatal injury from this one. So a couple of ideas is to work with the docs who put in the trach, see if they can use a more flexible device, a clear trach flange, a softer tube, so that we don't have that intense pressure, because there is edema that forms after a trach, and that leads to significant injury. You can get them into there was a study done on the use of hydrocolloid dressings in the OR, not my favorite, but I did need to be fair to what was in the literature. Sometimes surgeons will agree to suture with only 2 rather than 4. Many hospitals have agreed to take the sutures out between day 5 and day 7. And what we have seen is that not all the doctors come back and see the patient that they put the trach in, so they're not aware of the difficulty that we're having trying to work with this trach. So working again with Lexi, we're going to work with respiratory therapy and make sure that the securement device that we have, and you see a great one in the photograph there, it's wide enough that it's not going to cause pressure in and of itself. And we have seen, as I showed you, the fatal one, we have seen the securement device create a pressure injury onto itself. So the wider securement device is perfect in that it will hold the trach in place without causing extreme pressure. Do use longer straps for obese patients. Check for injury beneath the straps. We need to look at that every day, just like we should look at all of our pressure injuries. And if you have a patient who's very obese and has a lot of intertriginous dermatitis, you may want to line the fold of the neck with a silver dressing just to reduce the contamination from the skin. So the wounds in the perineum from urinary and fecal catheters are a problem. And the first case is the one at the top that I talked about. So here's some of the issues. We don't have a lot of sizes, and I'm not talking about French sizes, I'm talking about length sizes. So if you're dealing with an obese patient, as this patient on the top was, how do you know where the aspiration and inflation ports are? Because they're up under the pannus of the abdomen and you can't see them, and they're leading to pressure not only in the perineum but on the underside of the pannus. The other thing that we're seeing a lot of across the US is a number of male patients that have tears to the meatus, erosion of the penis, and actually what we call traumatic hypospadias, where the Foley has become so tight that it lacerates the penis. These are horrific injuries, and they can be prevented by using a leg guard and getting that Foley placed so that they're slack in the tubing and it doesn't create that degree of pressure. The problem is some of these patients are so large that the tubing itself doesn't extend beyond the large abdominal pannus. That's where I think a longer Foley would actually help us. How to stage these wounds is something NPIP is going to work on, because we have a problem here in that we have some mucous membrane and some skin. And so that's one of my goals for next year with the panel. So stay tuned, I guess. We need to get the catheter out. That's the other piece. And we need to recognize that if the patient doesn't need frequent, so that's hourly to Q2 hour monitoring of urine, they don't need a Foley. You shouldn't put a Foley in just because you don't want to deal with incontinence or just because they're in critical care. That no longer is acceptable. And when you try to put a Foley into a patient who has prostate disease, it makes it even harder. You create some false passages, and those can be extremely difficult to work with because they bleed. And I think that what you need to be looking at for your incontinent patient is a system of either a condom catheter or some of the new vacuum urine collection devices, just to get the Foley out of the way. So how do we document the assessment and prevention? I think that, to me, the simplest way to do this is to look at the skin under the device that's shift change. And why do I say that? I say that because you've got an extra person. You're doing bedside reports. So take the devices down. If I have to undo the trach ties, I really want somebody to hold the trach in place. If I need to take down the art line tape and look underneath the cock-up splint, I need somebody to make sure that the art line itself doesn't get pulled out. The exception for shift change is probably going to be the cervical collar. And the cervical collar, somebody needs to hold the head in neutral position. So I think that for us is neurosurgery or trauma or critical care so that we can take the collar off. You need to document what you find, and the documentation about what you find is documented as the status upon transfer of the patient to the oncoming nurse. And then the plan of care should change at that point to either pad under the device, move the device, remove the device. And of course, you need to let the skin and wound team know, because they may have some things that you aren't able to get a hold of. So here's a great example. of a medical device. This patient who has had a traumatic amputation. You can see it's not a clean stump at the end, so it was simply wrapped up to control bleeding, but wrapped up so tightly that the bandage caused a pretty significant wound on the top of the knee. That was found when the surgeons came in and removed the dressing. And of course, now we've got two wounds. We've got the open stump at the end of the leg, and we've got a pretty significant deep tissue injury on the kneecap. So one of the issues that we have, and this is why I said a while ago when I was asked about the low-hanging fruit, not all devices are easily moved. Here's a bunch of them. You can't just take these off because you feel like it. And we need to look at the neck collar. This is one that I think is a problem sort of all around. And I can't say I have the solution of all solutions, but I have a solution. So these are the types of collars that people come in with, and depending on how severe their neck injury is really dictates the type of collar. Why did we ever put people in collars to begin with? And so it started years ago when EMTs would pick up automobile accident patients and made a presumption that there was a head injury or a neck injury. And so they were placed in a collar at the scene and transported with the collar in place. And usually the collar was left in place until we could confirm that there was both no bony injury to the cervical spine and no ligamentous injury, which meant the patient had to be conscious. So the thought today, though, is that some of the things we thought we were doing right. So what we thought we were doing right was we didn't want the neck injury to worsen at a time when the patient's neck was not supported. And so there were stories around about the patient who didn't have a collar on and was able to walk from the car accident, but now 48 hours later is not able to walk. And they blame that on the collar not being placed. And so today, a lot of that is being questioned about maybe this is secondary injury from inflammation, less about the collar. So you may see some changes in practice. So let's talk for a few minutes about how you get that collar off and how you can appropriately assess the skin. Obviously, the big issue for Lexi and me is that it's really hard to keep an airway open when you can't tip the head back. So when you have a patient with an airway issue and a cervical injury, something's got to give, and the collars lead to significant injury. So here's my recommendations. When the patient's in a collar, you need to look at the skin under the collar every 8 to 12 hours. And inside most collars are removable pads that can be changed. The skin can be washed. Sometimes the patient's hair needs to be clipped. The beads need to be taken out of the head because EMTs are not going to do that. So you start with the patient supine, have a neurosurgeon, ICU, clinical nurse specialist, somebody who understands how to support the neck, maintain cervical alignment. So they actually take a hold of the head of the patient. You remove the upper section and you look at potential injury. You pad what you find. Now remember that darkly pigmented skin doesn't show change as quickly as lightly pigmented skin, a little harder to find. And so it's going to take some assessment on your part, see if you see indenting on the skin. You're going to look at the chin, the jaws, the ears, the shoulders, the sternum, and of course cleanse the face. Then when the collar's off, as I said, you can shave, you can change the pads, you can put the silver product in there, silver fabric, to help with infection. Now I want you to remove the back of the collar. And so you're going to log roll the patient on their side. Same person's maintaining cervical alignment. You're going to look at the occipital area and make sure that there's not injury. And sometimes you're going to find matted hair, you're going to find beads, you're going to find grass, you're going to find all sorts of stuff. This is your chance to clean all of that up and then put the collar back on. So there are other things that cause pressure injuries, pretty high incidence of some of those. That's a bedpan. This is an NG tube. This is what I call bed trash. I really don't know what that was. And then when people get, this is abdominal stage suture. When people get wounds from suture that's used to suture the abdomen, is that a medical device injury? I have a quick story here. I presented this case, you can see it's an old photograph. I presented this case a number of years ago, and one of the nurses in the audience said, that is not a medical device pressure injury. That's just what happens when you have abdominal surgery. I struggled. I thought, and I said to her, that is not just what happens. And if that's your attitude toward medical device pressure injury, your hospital is going to have problems. Elastic stockings are a huge problem. The patient on the upper right had a total knee done. Nobody had taken the socks off for 3 days. And when the socks were finally taken off, that was the wound. And the patient in the middle didn't like the way they fit, so she rolled them down and caused a tourniquet injury from the socks. So lots of issues. This is the one I've been promising to talk to you about. When you have a patient in a splint or a brace, it is absolutely imperative that your staff know that that is removable. Now, there's going to be a lot of anxiety about removing a leg splint, and that's what this thing is. This is a patient who had an unrepaired tib-fib fracture. And so there was lots of angst about, I don't want to take her out of the splint. It's going to hurt. Who's going to hold the leg? So this is a place where you can use physical therapy to support the leg. Look at the wound that developed from the splint. And yes, her leg had to be amputated. There was no way to heal that. Bariatric patients get medical device pressure injury. A lot of the time, the device is stuck up in a skin fold and we can't see it. And so I think we have an issue here with devices that do not come in sizes. So some of the recommendations that came from the secure manuscript, really we've been talking about, you've got to get the size right. You've got to consider both elderly and children at risk, elderly because of their high rate of arterial disease. Get something between the device and the skin. I highlighted, italicized the big one, remove or move the device to see the skin. Do think about the edematous patient and recognize that you can lose a device in obese skin. This is a document, or I should say a figure that came from the secure document, and it's just wonderful. It really lays out the whole story. So we've been going through all of this, but let me just kind of land on this as my close. You need to do a thorough assessment of the tissue under the device. And it's easiest if someone will help you. You need to make sure that everybody knows that devices can lead to injury. Obviously, a number of you have listened to this, so you must already know that. You should lead the adoption of best practices of how you reduce the risk, how you get the right size, how you examine the skin. Make sure that you, before you start this champion project, understand what's leading to the injury. Is it the hardness of the plastic? Is it the fact that we're not padding? Is it the fact that we're not looking? Report them. Only with data do administrators change their practice. So use the data to help you. And then I do think this last piece is really important. It's keeping track of the devices. Because if you said to me, I've got a whole bunch of medical device pressure injuries, what would I say to you? From what? From which one? Once you start to say to me, well, we've had a whole bunch of them from neck collars. Okay, good. Now I know where to focus. So when you do your recording and you do your big pressure injury prevention prevalence and incidence, get the type of device in your record, because you can't make a change when 41 devices are the problem. So I'm going to turn this back over to Lexi to moderate this. I'm certainly open for questions. I'm going to have a slug of ice water before I start answering questions, but I won't go away. Lexi, over to you.
Okay, thank you, Dr. Black, for that very
Lexi, do you want to try
thank you,
again?
Dr. Black.
I know we're having a little bit of issue.
Okay, let's try that.
Thank you.
Thank you, Dr. Black, for that very critical topic session. I would like to inform our viewers how to receive their CEs for this session. This activity has been approved for the program for 1 contact hour. You can obtain those continuing education credits by logging on to www.saxtesting.com/P. You will need to register on the test site, complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an educational grant from Dale Medical Products Incorporated. An archive on-demand version will be available on www.perspectivesinnursing.org. The on-demand version will be accredited for CEs. And now we have time for a few questions. We've had some really great questions come in during this session. So Dr. Black, I like this question here myself. Do you recommend the application of placing polyderm on all patients using BiPAP masks or selectively on patients who are susceptible to injury? The question is, doesn't placement of the polyderm lead to more leaks and more tightening? What is the need for placing the polyderm if the patient uses the mask PRN or on and off for every 4 hours?
Well, I don't know that you need to pad the skin if the patient doesn't have it on continuously. I think, Lexi, the big problem we were having is when the mask got clamped down tight to the face so that there wasn't a leak. I think that was really the genesis of the problem. Polyderm can be fairly thick, so be careful you're not creating a gap, a space between the edge of the dressing and the skin, which would cause greater leak. But no, if it's PRN, I mean, people sleep in CPAP all night and don't pad their faces. So I would say I don't think you need it. But if you're continually assessing the skin, you would see the development of redness, and then you might jump to the dressing.
I agree. And to your point earlier about checking it with 2 patients, with 2 providers in the room at shift change, I always like to see respiratory therapists check it with nursing so everyone's on the same page and can get a look at it at least once per shift, and then more is needed, but it's nice to have that multidisciplinary set of eyes on that. Here's another good question we have. We have seen an increase in granulomas in long-term trach children located in the area of 6 o'clock of the stoma. Would you recommend early silver nitrate treatment from them getting worse, or being seen to have them cauterized? If they're not treated, they tend to split and separate, causing a much larger stoma. Do you have any suggestions for this?
Well, I think a common treatment of granulomas is silver nitrate. I would start there before I would do anything more aggressive and see if it's working. Once the stoma is healed, you should be able to move the tube around to get the pressure off the 6 o'clock part, because what that is gravity is pulling that tube down. So you may be able to just reorganize how the tube is coming out of the stoma and reduce some of that pressure, because that's really the story of the problem.
Okay, here's another question we have. This is from a respiratory therapist who works in a level 3 NICU, and they would like to know about patients who are intubated, both full term and the neonates, a suggestion to cut back on pressure injuries. They are not able to change the positions or the tape on the ET tubes because of it would just be too harsh on the baby's skin. So they check everything Q2 to Q4 on all oxygen devices and add a dressing under it if they can. However, they do not retape. They only move ET tubes if necessary, and they do use a mesh tape. Do you have any suggestions that might help them out?
I was wondering about a skin prep on them, and to be honest with you, I do not know the safety of some of the skin preps to reduce the damage to the skin when you pull that tape off. Lexi, maybe you know how the various skin preps that we use to prevent tape burn, if they're safe on a neonate. I have a very good friend who does nothing but neonatal stuff. So I'm going to recommend you talk to her, but Lexi may have an idea also.
I'm not sure specifically on neonates, the difference, if it would be different recommendations for an adult. But when you were talking about low-hanging fruit and going over that, one thing that came to my mind is one thing whenever we were working on decreasing our pressure injury rate is to our BiPAPs that were going to be going to the emergency room or used acutely, we added the skin prep and the small pieces of Mepilex to the actual BiPAP bag, setup bag, so they were readily available. And just having that available is really important. I feel like skin prep is sometimes an overlooked piece of the puzzle. I think we have time for one more question here. Let's see. Okay, so the comment before, device manufacturers now have a variety of different BiPAP masks that can be used to alleviate pressures from certain parts of the face. So offloading, you can switch masks around. Some ET tube holders now have the ability to be moved from side to side in the mouth. Does your RT department have access to these type of oxygen-related devices? I would say they're pretty common. What do you think, Joyce?
Yeah, we have all of those. The issue that we struggled with, this is a number of years ago, I will admit, that nobody knew whose job it was to move the ET tube, so it didn't get moved. And so now it doesn't matter who moves it, because in order to do oral care, you got to move that ET tube out of the side of one mouth or the other. So it became a combination of respiratory therapy in critical care. Respiratory therapy is there, easily there and often there. But it wasn't what we struggled with was, well, that's your job. No, that's your job. Well, how about it's both people's jobs? Because it was scary for some to move the ET tube. Sometimes the patient has a gag response. There was fear that they would extubate the patient. I was like, I don't think that's a fear. I mean, we're not yanking and moving, we're just moving.
Thank you very much for that. And thank you to everyone for attending this webinar. I will now turn the presentation over to Tracy for some concluding remarks.
Thank you, Lexi, and thank you, Joyce, for that great presentation. We'd also like to thank everyone for attending the webinar today. Please note, immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback, as well as your CE certificate of completion. In 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. That's www.saxtesting.com/P. Please keep an eye out for that. And again, we'd like to thank Joyce for presenting this webinar today and thank everyone for attending. We hope you have a great rest of the day.